Well, folks are coming to the microphone. Perhaps if I could ask, Ram, what do we know about the status of the myocardium in those borderline under the EFE? Is the myocardium of the left ventricular myocardium, is it healthy?
That's a great question. We suspect that the myocardium is not normal. Our colleagues, Andy can probably comment on this as well, but we're trying to learn more through imaging to try to understand that. We have taken biopsies at times from papillary muscles and other areas as we're resecting EFE, and it's clear that they have a potential to lay down more scar tissue, more EFEs. So I think that fibrosis is a part of this. I just don't know to what extent we have that, and how to distinguish the patients who don't have that from those that do. Andy,
good, sir.
Thank you for the nice presentations. I would like to ask to Dr. Powell. I was thinking that both entities that were presented were pretty different one from the other. And I think some things might be taken into consideration when talking about univentricular left, borderline left ventricle, comparing with when you talk with unbalanced atrial septal defect. So I was wondering if you used some echocardiographic variables that had been really consistent over time, which are, for example, the modified atrioventricular valve index or the right ventricle, left ventricular inflow index in surgical decision making.
Well, first, I agree that those are two different situations and they should be considered differently. For the unbalanced canal defect, we haven't relied heavily on the AV valve index, to the best of my knowledge, in our surgical decision making. A lot of it has to do with the morphology of that common AV valve and how it's attached, particularly on the left side. And the surgeons can speak more specifically to this, but they're able to divide the ventricle and divide that common AV valve in such a way that it can essentially move some of that AV valve tissue over off to the left side.
Exactly right. I think that what you want is an adequate sized left-sided orifice, and when you're looking at it on an echocardiogram, the distribution of the leaflets over the ventricles is not necessarily what has to be the case when you're operating surgically. So what we'll do is change our septation location on the AV valve such that we're not limited anymore by where it naturally needs to fall. We use a two-patch technique, and in my mind, that allows us to really redistribute the valve in a way that I find is not as possible when we're using a modified single-patch technique or the Australian technique in which the leaflets are placed down onto the crest of the VSD.
That's great, but how do you deal with the left ventricle inflow? Because in that way you can divide the valve in the appropriate, in the exact location, but you cannot work on the left ventricle inflow. And do you take that into consideration, the left ventricle?
So what I find to be a better marker of problems with separating the valve is really how the papillary muscle architecture is. So we focus more on what does the subvalvular apparatus look like rather than the AVI index. If we have a single left ventricle papillary muscle, closing the cleft will result in a terribly stenotic valve. And so in that situation, we will have to use other techniques to either create two papillary muscles, if that is possible, or to only partially close the cleft or patch the cleft so as to not compromise the inflow to that valve. And I'll be I think at one of the sessions on Wednesday, I'll be describing some of these techniques that we're using. But again, it's on echo, I'm looking more at the subvalvular apparatus than I am the distribution at the level of the annulus.
And what about the BSD size? Have you taken a look inside that? Because the BSD size has shown to has demonstrated to be a marker of higher mortality. If you have a larger VSD, you have more mortality. Do you look into that before taking a decision?
You know, I would say that probably the patients that we see the most trouble with are transitional AV canals. I think it's the large VSD patients. It's much easier to distribute the valve over the ventricles. It's when you don't have a VSD, or when the tethering attachments of the superior and inferior bridging leaflet limit the ability to maneuver that leaflet and redistribute it. What we find we have to do is actually cut many of those attachments to then create a VSD, a large VSD, and then close it separately. And I found that to be very helpful.
Thank you very much.
Andy, this is a question for you. So when you're looking at these ventricles, one of the things that you actually see is that they're much globular than a typical spherical-looking ventricle. And we know that globular ventricles do not tolerate pressure that well. And actually, long-term wise, they have a higher chance of failing than a spherical ventricle is. So have you looked into, because one of your MRIs, if you look at the septum, it looks, the movement of the septum is actually very abnormal. So have we looked into doing some regional wall motion studies, or using feature tracking or strain analysis or whatever, to kind of see whether there's any regional wall motion abnormality in these ventricles who are getting a biventricle kind of repair on borderline ventricles?
We didn't specifically look in that. So we didn't look at feature tracking or any regional measures in that study, nor did we look at any measures of sphericity, which we could, of course, go back and do. Right now, those three parameters are the ones that we primarily focused on, but thank you for the suggestion.
I mean, I say it's truly remarkable what you're doing. I think we're really all learning from you and what you're in the program that you're running, I guess. But my question, nevertheless, is that clearly a lot of your patients are not sadly going to make it through a biventricular pathway. And when we look after our single ventricle patients, the things we want to do is we do not want to volume load the circulation. We do not want to give them a restrictive atrial septum. So are you worried that the patients who don't make it are going to end up turning a good fontan into a bad fontan? And are there lessons you're learning as to the patients that you should have bailed out on earlier, or you shouldn't even have embarked on the progress?
Well, we're certainly learning. That part I can answer very easily. The patients who have undergone single ventricle palliation after recruitment, for the most part, have not suffered as a result of it. So we've continued to the fontan, and the key there is to make sure that they don't reach a certain threshold where their pulmonary vasculature starts to see irreversible changes. And this is where the monitoring period becomes important. It's important to make sure that you follow the gradient and bring them back for catheterization if there's any concern for restriction of the atrial septum that's leading to elevated pressures. I will say that a lot of the patients that were in this series were also not necessarily candidates for fontan, either because of right ventricular dysfunction, significant tricuspid regurgitation. So we're pushing a lot of patients down the biventricular repair because they have risk factors for single ventricle as well. And many of them kind of stay in a Glenn plus a shunt territory for a period of time until we can determine what the next best approach is. But I think it's very important to monitor them very carefully and intervene early. But if you do that, you don't burn the bridges for a fontan ultimately.
How do you go around the way you counsel these patients in a period of intense public scrutiny, where one patient that you lose could have been a fontan, a good fontan?
Well, I think it's very important early on to engage them. One of the nice things about the staged approach is because it's over a period of years, you have an opportunity to really discuss with the families the options. So you're not committing to one approach versus the other. And we have many opportunities to discuss. So I find that many of the families, when they come to a biventricular conversion, are much more prepared in terms of the expectations, what to expect afterwards. And I often kind of show them the same slides I show at a medical conference, and make sure they understand the risks and benefits.
Yeah, there's no question these are hard conversations. They're long conversations, and often it's multiple conversations where you kind of reinforce what you said before, answer a new round of questions, and kind of go over things in maybe a different way of presenting it, just to make sure I need to be confident that they understand the benefits and risks of trying to do something like this. So it really is an example of shared decision-making between the providers and the patients and the families.
Excellent. Thank you very much.
Please help us improve the content by providing us with some feedback.